Good evening. I'm Blackie Swart from Cape Town in South Africa. I'm a maxillofacial surgeon and currently the president of the SAO. In this very difficult times of COVID-19 and the uncertainties about this, we have set up this WebEx programs already from the beginning of the year with one every month. And I hope that you would keep following us and get a free webinar from the SAO every month. This month it is my turn, and I refer you to the registration form, but please keep checking up on our website and our contact number to learn of the status of the conference, because I think there might be quite far-reaching implications from this COVID-19 virus. And therefore we will keep you informed about what is going on in our conference. But as yet we are building up to the conference. Tonight I would like to introduce especially the younger dentist to CBCT. Once you have received your CD and you've opened that up and you've installed the program, that is where I start. I am not going to talk anything about reasons why the CB was taken, if it was correct decision making to do the CBCT, or any of the technology of the CBCT. I would like to give you a practical guide which you can use in your practice from tomorrow, because lockdown starts straight after that. So I would like to just also, before you make that judgment of that CBCT, we must adhere to the ALARA principle. And the 3D reconstruction, you must also remember, is a reconstruction. So it is cuts in the axial format, and those are reformatted to form a 3D image. So saying that, the newer technology and the newer computer software is so good that we would hardly notice a mistake. And now with artifact being diminished by software, but remember, it is software. I would just like to touch two small points before we go over to the practical side. The first is the voxel size. The voxel size, that is the pixel size on the flat area of the detector. So it depends on your product that you use, how big this voxel is, but a voxel and the computer program can only interpret what it gets on the screen. So if you have a lot of artifacts, so-called hard beaming, and it does not reach that detector, it cannot give you an image, but the computer interprets it and gives the average value between the most common values that it can see. So it depends on the manufacturer, the matrix size of the detector, and the smaller the voxel size, the higher the spatial resolution. And at the bottom you can see what is cone beam CT and how does it work by Scarf et al. A very good paper that you can go and look at. The smaller voxel sizes equal higher doses. But the biggest mistake that I commonly see is that the people would want to go too low. If you go too low, you get a degraded image because your computer has got to make a lot of extra assumptions, especially if you're going to use it in endo work, in root canal treatment work. You have to give sufficient radiographs. The software can work around this and give you the precise detail that you want to see. So select the most appropriate dosage, and ALARA does not mean too low so that your image is degraded. And this The dosage obviously depends on the patient factors, the artifacts that is created, and mostly for us by fillings, crowns, posts. All of those gives artifacts, and the artifacts takes up the beam of the X-ray that goes through that, and it cannot be interpreted. Try to minimize radiation deterioration, such as occlusal contacts. So if the patient comes for an X-ray, try to let them just keep the teeth apart a little bit, so that we do not absorb that whole stream that goes through that, the so-called hardening or beam hardening effect. A good tip to get better definition is to put a cotton roll between the teeth and the cheeks, and thereby you get a nice black area that is easier to interpret. The artifacts is factored in by the patient himself, the size, all of the factors that I've known above, the acquisition thereof, the scanner related matters, and then the cone beam itself related. The last thing that I would like to say before going over to the practical side is what is cone beam related artifacts. The beam projection geometry of the CBCT and the image reconstruction method produce three types of cone beam related artifacts. Partial volume averaging, and that's what I've been trying to say all over. The computer program takes 2 points and takes the average point between those two. The wider those two spatial differences are, the worse result you can get, or not worse result, but inaccuracies of duplication of anatomy. Undersampling, another very important factor. And then the cone beam effect itself, which with the newer and later cone beam technologies is really not relevant anymore. It gives the little stria or stripes at the sides and ends of the CBCT. Undersampling can occur when there are too few projections are provided for the reconstruction. A reduced data sample leads to misregistration and sharp edges and noisier images because of the aliasing, where the striations appear in the image. This effect may not degrade the image severely. However, when resolution of fine detail is important, undersampling artifacts needs to be avoided as far as possible by maintaining the number of basis projection images. Thus, for root canal treatment, it's extremely important, and also if you want to do something surgically guided. The monitor. I am looking in front of me at an X-ray monitor as suggested by the SABS. Unfortunately, I have read up quite a few articles on this, and a high resolution monitor as those that you can see with Apple gives the same result as a medical grade monitor that costs a lot more. So this is basically the images that we're going to get at a cone beam CT. Let's go to see how we use it in our daily practices. The first thing that you've got to decide is the volume of interest that you are going to take. Because if you're going to take a big 17 by 13 volume, you've got to be able to interpret that image that you get. As you can see on the right hand side, you must be able to diagnose and interpret cervical vertebra. You've got to be able to look at TMJs. You've got to be able to look at orbita. And so it becomes smaller and smaller to a level of 5 by 5. And the 5 by 5 gives us a 90 voxel. A 10 by 10 gives us 180 micrometer, not voxel, excuse me. It's a 5 by 5 micrometer acquisition that you get with very fine detail. So be careful if you have a machine that can take large images, that you just not routinely take them all, because you've got to spend the time and have the knowledge to interpret this information. The field of view. If you have this huge images every time you take a CBCT, you've got to read all of those cases, because there was a lytic lesion in the clivus, and from the study, which included the findings by the University of Florida, you can see that in 653 incidental findings were found in 309 out of 400. So 309 images that was taken out of a possible 400 had incidental findings that needed further attention. If we looked at those incidental findings, 31% of them required referral to another specialist, 17% needed additional monitoring, 51% did not require either. So half of these incidental findings needed further referral. And if you look at those two images and you cannot immediately see to what I am referring, you should not take large field images and interpret it. Rather leave it to a radiologist or an experienced person to look at that, because this is the osteomeatal complexes, and by the way, that is my own CBCT, and this is a fibrotic band from an arthritic lesion in the TMJ. So if you cannot interpret these views, do not take them, and you do not have to take large field views. In fact, in my own practice, I keep it down to 10 by 10, because with a 10 by 10, it's the anatomy that I use every day, and I can easily interpret these results. If you want to learn more about the anatomy of the maxillofacial region, this is an excellent article. Remember, this is recorded and you can come back to this. If you want more information and you cannot get to the recording of this session, please email me and I will forward this article to you. It's one of those that I keep in my own desk to refer to if need be. Now, this is a real patient. We are actually busy with this patient. So he presented to us and he wanted the ideal treatment to restore his dentition. He knew that over the years many things have been done, and you can see with me that he spent many hours in the dentist's chair, but now he wants to have it properly fixed the best possible way that we can. So what are we going to do? First of all, the clinical examination. And with this, I must refer you to our next WebEx, which is going to be periodontal screening and evaluation by Dr. Mulder, which will be in a month's time. Because after you've done your clinical examination, you can then go and do a CBCT. And this is what it looks like after you've opened it from your CD and it is on your monitor. If I could choose 4 factors to show you what to look for when you get this image, this is the following. The first is you must know how to enlarge a specific field. So there's the button where you can enlarge the field. You must also know what the mouse can do. The mouse can enlarge it or you can slide through it. And the buttons on the right hand side, because everybody will play around with these images and get totally lost. So do I. But the buttons, the circle with the arrow on the right hand side, revert to that and you get back to point 0. And then, or third point that's important, is the three-dimensional image that is created. And with that, you can adjust the three-dimensional image, because that's going to give you an idea. You cannot make a diagnosis on a three-dimensional image, but it gives you an idea of where you are. And obviously, to take images and photographs of that images. The photographs I use extensively, just to remind and to jot to me, and also to make up my reports. So let's start off. So the first is I've enlarged the three-dimensional image, and from the left-hand side I can see the dental problems, the periodontal problems. I then reselected to the initial stage again. Once again, on the left-hand side I can see where the problems is, and I also want to look where I want to place possible implants, and there I can see there's possible problems. So that is the first step in interpreting CBCT, is get an idea in your head what's going on, and therefore the 3D image is very nice to start off with. The second is that all images is taken in the axial view. So I like to start looking at the axial view. So I use this every time I open a CBCT. So I go to the axial view, and as you see, I went to the most superior part. And now with the wheel on the mouse, I scroll down until you get to the end. We are often so encountered with a problem that we want to see that problem at first. And what we do is we zoom into an area immediately to see what the problem is. But you have to have an overall view first of all. So this is what you are going to see on a CBCT. That is the anatomy, and you can just to remind you back of your anatomy classes of all the muscles, all the structures that we are going to go through. And this is then how I start. I look at the septum, I look at the maxillary antler, I look at the vertebra. Okay, and this is how I look. And on the mouse you'll see it getting orange. That is how I go from superior to inferior and looking at any problems that I can foresee. Here you can start seeing, I'm seeing some opacification in the sinuses. Immediately I take an image because I'm going to come back to that. And then I scroll further, and now you can see opacifications. But remember that you are already coming down and not seeing the upper part of the maxillary sinuses. Here you can see the teeth coming through, evaluating the nasopharynx. So you see, and there in the there's one area in the 1-2 area, and I can start seeing more pathology. Now I need to know what's going on there, but don't go and look at it yet. You are going to come back to it. Make notes as you go on, because you need to come back to each and every one. And if you start jumping around, you haven't got a consistent way of looking at an image. And here we are going through the upper teeth, and you can see all of the scatterings. I especially took a case where there's a lot of scattering, a normal patient, not an ideal case, which a manufacturer would like to show you. And here you can see the artifacts and the stria, the hardening, beam hardening, and also the total absorption of the radiation that goes through. And then we go through to the mandible, and in the third quadrant you can see there's an area of freshly extraction wounds that is healing. And then we go right through the image in the axial view all the way through the mandible You can see any other pathologies at this stage. I always say I look for major things whilst I'm going through here, but I make detailed notes of what I see. That is the soft tissue, that is the suprahyoid muscles, the submandibular glands that you can see in this image. And then I have gone through the whole image from superior to inferior so that I can make informed decision of what I want to look at further. This is what my normal shorthand of what I do whilst I'm doing that axial superior to inferior view, so that I can go back to each and every point and make sure that I do not miss out. So I'm not going to go through this whole case with you. I'm going to show you one problem identification, how I look at each problem that I've identified coming through the axial view. And then, because we're an implant society, I'll show you how we plan some implants. But first of all, let's go and look at the problem identification. So once again, you can see I'm going to look at the 2-8 area. So I go with the yellow bar, the horizontal bar, to the level that I want to be. And now I can rotate my angles, my two-dimensional planes, so that I can be perpendicular to the problem. And in this case, I'm looking at it in a sagittal view. And then I'm running with the mouse, I'm going sliding through it in a sagittal aspect. And you can see that this molar is definitely not savable. Both of these are really not savable. Although I would take a second look at the first molar in a second run. This is only for the third molar run. And remember, I've just shown you only the sagittal. Obviously, here you can see the coronal part, and you can also go in the coronal from the front to the back, or from anterior to posterior through the images. So thereby you get the best quality of the problem that you have. After this, a problem list can be fully compiled, and you and the dentist or you and the specialist can make a full treatment plan from this and adhere to this. So we did a treatment plan after looking at all of the problems, and this patient needed extended treatment. But one of the wishes that he had at the end of it was that he wanted implant supported teeth in the posterior so that we could reconstruct the anterior in a more effective way. So I'm just going to show you how I do the implant planning in the third quadrant. So first of all, I looked at the curved view in this instance. So first of all, you've got to determine which field you are going to look at. So you determine the arch of view which you are going to look at. And if I look at the mandible, I like to do it at the level of the inferior alveolar nerve. And once you have shown the curve that you're going to look at, I start looking to identify the inferior alveolar nerve. And here you can see I start at the mentalis foramen. So I go and determine where the inferior alveolar nerve is to the mesial point, and then I can go on the panoramic view, select the nerve, and then scrolling through the panorex until I can see the nerve clearly, and then I can mark the full inferior alveolar nerve on my 2D image. And from here I would like to know a little bit more depth. So looking at it like a panoramic X-ray, I put the thickness of it at 14 millimeters. And then I measure the distance of the defect in the third quadrant. And here you can see the defect is 20 millimeters. So immediately when I see that defect and I see 20 millimeters, I see two premolar sized teeth of 5 millimeters each and one molar of 10 millimeter. So remember, this is only the planning stage. I'm not talking about further software digitization and planning. This comes afterwards and is much more in detail. So here you can see I made a 5 millimeter measurement, and I can put my graph and coronal cut on the 5 millimeter, and here I can place an implant, and you can see, yes, it is an implant, but the length of it I can most probably shorten. So the 12 millimeter implant, I would like to go to 10 millimeters to give me the freedom of not touching the nerve, and then I can place it so that it fits into the superior tooth. And for me it's always important, and I like the little arrow at the top because that is in the interocclusal fossa, and I know that it is ideal. And even though on the 3D image it looks as if the implant is totally out of bone, on the coronal view I know that there is sufficient bone for that. So at the back I'm going to place then one premolar implant in the anterior, another pontic in the middle of 5 millimeters, and in the distal of 10 millimeters I want to place a molar tooth. So there seems like there's a lot of bone on the panoramic view, but obviously we already saw from right in the beginning that I'm going to have a huge problem here. So placing an implant in the molar area, I find that there is only 6 millimeters of bone available. And that is the total amount of bone that I can play with. I would like to know where the implant is going to make contact. So for that reason, I would also take the coronal view and make it thicker to 14 millimeters. And suddenly I can see where my implant is going to be, or how the occlusal level is going to be after implant placement. And once again, reset it from the front, and you can see that both of these implants are going to make good occlusal contact. That's the ideal that we want. And remember, from here I then take all of this information, I send it to the dental technician. The prosthodontist takes a digital scan which we superimpose on each other, and then we start planning and making sure that the implants are prosthetically driven. The only reason what I've done until now was to see if it is possible for me to communicate with a prosthodontist that implants is a possible treatment option. And this is the actual case at completion of the placement of the implants. We are now about just over halfway with this treatment plan. And if you had looked at this X-ray before you had seen the CBCT, you would have surely had criticized me for using such a short implant in the posterior. But as I proved to you, that is the longest implant that I could get in that situation. But being a broad implant, I'm quite happy that we would have a favorable result in the end with a 3-unit bridge with 2 premolars. We would then have 3 mandibular premolars planned and 1 molar. So to end off, I would like to show you some interesting cases. I cannot give you an extended view of all the cases that I've seen, but just a few of the cases that I would like to share with you. One of these is sometimes implants are not quite accurately placed, maybe because of inadequacies of surgeons or maybe inadequacies of radiology, because if you took a normal x-ray of this implant, it actually looks quite favorable and well in the bone. But obviously I do not have to show you where this implant is actually placed. I took out this implant and replaced it in the proper position, and I can say to you that the patient is quite happy at the moment. And even with this little amount of bone that is attached, the implant was fairly stable. It was easy to remove, but the patient could still function on this, but it was not ideal. Thus, I replaced the implant. The next is for general practitioner, more work. Caries is very easily to detect. It's one of the easiest things if you do not have artifactual problems. And I see it in a lot in impacted canine cases where I find carious lesions, and I can then take a picture like this and send it to the dentist. Now, this is not to say that each and every patient should get a CBCT. A CBCT with a radiation dose linked to it must be a careful clinical decision to decide to do a CBCT. You can also see fractured teeth very easily, and in this case you can see the posterior superior alveolar artery, and anybody that does implant surgery and does sinus lifts has come with lateral sinus wall lifts, has come across this artery, which can be quite an annoying bleed. But if you know where it is, you can plan around it or make alternative plans. Then this is a odontoma, and you can see the odontoma in the second quadrant. But what is nice is that you can put the cuts together, and these odontomas is 1.1 millimeter. You can make these cuts up to 2.7, which I normally use, or 4.5 apart. This cut was 1.1 millimeter apart, and I now know that that represents 3.3 millimeters, and that's more or less the odontoma that I found in the axial view. Pressure damage caused by a canine, the 2-3 on the 2-2. This is a case that I operated on last week. If an unerupted canine does not appear by the age of 9, have it examined, because this patient, a young patient, where the canine could not distinguish between primary teeth or permanent teeth, and unfortunately we had to remove this lateral tooth, and we are going to keep the space open for an implant at age 18 or 19, or when it is most clinical relevant to this patient to use. Now, to end off, and the last case that I want to show is a case that typically come to your practice in a mixed dentition. So this case was referred to me because there seemed to be a few problems. And if you look at these problems, let me show you what the first axial cut of the maxilla was. This was after I'd gone through the whole of the axial view from superior to inferior. And you can see the positions of the 1-6, the 1-4, the 1-2, the 2-2, and the 2-6. Now this is a 10-year-old girl. Now if we look further into the 1-6, you can see that the 1-6 is almost totally destroyed and it is not savable. If we look at the 1-4, you can see that the root of the 1-4 is 50% gone. if you look at the 2-2, which I can see in this image, you can also see that the defect goes through to the pulp of the tooth. And this is what the 2-2 looks like in a rotated view. Remember how I rotated the view? You can rotate it any way to make a tooth linear and perpendicular to the view that you want to look at. And remember, if you get lost, remember the round circle with the arrow, just press that and it would reorientate you again to the levels that you want to be. The third view is the 1-2. Now look at the 1-2. That's also a problem. Again, the 1-4 almost totally destroyed, and the 2-2 again with the problem to it. And if you look at the 1-2, you can see that a great deal of its tooth root has been destroyed by the erupting 1-3. And then lastly, if we look at the 1-4, totally destroyed almost, the 1-6 almost totally destroyed, and so is the 2-6. You can see the relevance of information that I can give through to the orthodontist, because from this we can change our treatment plan completely, because we do not have to guess of how much damage there was to the underlying teeth. And with a proper orthodontic workup, we can plan for implants in an adult life. So, in summary, I would like to say CBCT is a great advantage in dentistry. The sound clinical judgment to expose a patient is critical, using the ALARA principle, but do not be stupid about it. If you give too little radiation, the computer can only give you back what you give him. And if it gets a poor image, it's going to take the points that it recognizes and link the two. Develop a systematic approach that you use with each and every case. If you do not have a systematic approach, you get lost and you lose sight of the bigger image, and you can miss pathologies that could easily have been seen. Attention to detail helps in identifying problems. Do not zoom in immediately on a specific problem. First acquire a total picture, and from there you zoom in closer, zoom in more, until you have found and identified all of your problems. Do not hesitate to get a second opinion or have the CBCT read by a radiologist. I read x-rays every day, yet it is no problem for me to run up to the radiology department and get a second opinion, and I do it often. Do not let your ego stand in your way. Get a second opinion. It is to the best of your patient. And with this, I hope I've given you a little introduction into the intricacies of the CBCT. It's a wonderful tool to be used, but we must use it responsibly. I thank you for signing in tonight, and please, we would like to welcome you back. With this COVID-19 problem, we can still sit on this side of the camera, and in a month's time we will bring you another interesting lecture. Good night and good luck with the shutdown, and good luck with the COVID.